call the meeting back to order. And we're going to move to agenda item 6C, minimum standards for health benefits plans. Ms. Green, whenever you're ready.
Thanks again, Mr. Chair and members of the Pension and Health Benefits Committee, Marta Green, for the third time and the last time today. This is agenda item 6C, which is an action item requesting your approval to pursue proposed amendments to existing regulations regarding risk adjustment to ensure our regulations are consistent with the just approved risk mitigation strategy. These are found in the section of our regulations that pertain to minimum standards for CalPERS health benefit plans. The existing regulation is obsolete and outdated, and we're proposing changes that fall into two basic categories. So there's the revised category and the remove category. Here are the sections that we're proposing to revise. California Code of Regulations, section 599.500X. So the purpose of this amendment is to update the definition of risk adjustment to reflect current actuarial science. This amendment is non-substantive technical change. California Code of Regulations, section 599.508A8. The purpose of this amendment is to make non-substantive technical changes. This amendment is necessary to provide greater system flexibility in managing health risk by deleting outdated references. California Code of Regulations, section 599.508A9. The purpose of this amendment is to delete an outdated monetary reserve requirement for CalPERS health benefit plans. This is actually not directly related to the risk mitigation strategy. However, it is found in the same general section of our regulations as the risk adjustment provisions. And since we're reopening this regulation for the new risk mitigation strategy, it is timely to fix this outdated language that has been in our regulations since the 1970s. This change has no impact on our current healthcare fund reserve policy. The section we are proposing to remove are California Code of Regulations, section 599.508A8A through 8E. So this will remove obsolete processes used to administer the previous risk adjustment. So it articulated all the ways in which the old risk adjustment program was administered, while still requiring health plans to participate in any risk adjustment methodology as chosen by the CalPERS board. If the committee approves these changes, we'll submit our public notice package to the Office of Administrative Law for processing, and we'll return to the committee in the coming months to request approval of the final rulemaking file. So this is just to begin the rulemaking process. That concludes my presentation, and I'm happy to answer any questions.
Thank you. So far, I'm seeing no request to speak. This is an action item. What's the pleasure of the committee?
Move approval.
There is public comment.
Moved by Mr. Rubalcaba. Is there a second?
Second.
And Mr. Miller moved it, I think. Mr. Miller moved the.
I'm sorry. Thank you.
But I'll second the motion, Mr. Speckler.
Very good. Mr. Miller makes the motion. Mr. Rubalcaba seconds the motion. Any discussion on the motion?
Rob, this is Cherie.
Yes.
There is public comment on this one.
I see that. I was just seeing if there's anybody else before we move forward.
Okay.
All right. Seeing no one else wishes to speak, Mr. Fox.
Yes, Mr. Chair, we have one speaker on item 6C, JJ Jelencic.
Hello, I was not on 6C, I was on 6D as in David.
Very good. We'll get back to you then, sir.
Thank you.
All right, seeing no one else on item 6C, the motion being before you, Ms. Hopper, please call the roll.
Margaret Brown?
Aye.
Henry Jones?
Aye.
David Miller?
Aye.
Irena Ortega?
Aye.
Ramon Rubalcaba?
Aye.
Teresa Taylor?
Excused?
Shonda Wesley?
Aye.
Karen Green Rochford Betty Yee?
Aye.
Mr. Chair, I have all ayes. David Miller making the motion. Ramon Rubalcaba seconding on agenda item 6C.
Thank you very much. Thank you, Ms. Green. Moving on to 6D, long-term care optional benefit design and premium changes. Mr. Moulds. You're muted, Dawn. There you
Sorry
go.
about that. Is that better?
It is.
Great. Apologies. Good morning, Don Mold's CalPERS team. I'm here this morning with the task of leading you through a discussion about raising rates in the CalPERS long-term care program. We're in an unfortunate situation where any resolution is going to add to the financial burden facing our policyholders. Over the next few minutes, I'm going to discuss options our team has developed in an effort to lessen those hardships while also protecting future benefits for policyholders. I think it's helpful to begin with a review of where things stand with respect to the long-term care program. Back in the spring, the team alerted the board and the public that CalPERS was facing the potential need to reduce the discount rate for the long-term care fund in light of recent returns of fixed income investments, which are the long-term care fund's primary holding, and to adjust actuarial assumptions in the model it uses to project future costs. In September, our chief actuary, Scott Tarando, shared in the Finance and Administration Committee that based on the work conducted by his team and validated by outside actuaries, the long-term care program is about 69% funded and faces a shortfall of about $2.1 billion. He also shared that absent intervention, we would need to adjust the discount rate for the long-term care investment fund from its current 5.25% down to about 4%. Given the challenging situation and the resulting potential for extraordinarily high rate increases, we committed to engaging in a thorough process to consider every possible option to minimize the rate increase, maintain the sustainability of the program, and protect the coverage our policyholders are relying on. Specifically, we've been exploring two ways to lessen the needed rate increase. The first is by taking action to improve our investment returns. The second is through changes to the benefit design, which policyholders could take up on a voluntary basis to provide rate relief. Yesterday in the investment committee, you heard there is room to improve our projected returns. Doing so reduces the total premium increase needed by about 40%. But as you also heard, even with the improved discount rate, stabilizing the long-term care fund will still require significant premium increases. Today in PHBC, we are seeking your approval on two items. The first is a premium increase that will apply to all long-term care policies. This will be divided unevenly over 2 years. The second is approval of components of an optional benefit package that policyholders may take up in lieu of that premium increase. I'm going to start off with the premium increase. As you heard Scott and Christine articulate Monday, based on the revised discount rate that was adopted yesterday by the investment committee, we are proposing for your consideration to reach the amount of the needed premium increase by raising rates over 2 years. The first increase would be 52%, and it would be implemented starting in July of 2021. A second, smaller rate increase of 25% would go into effect 1 year later in July of 2022. There are a couple of reasons why we're proposing a 2-year rate increase that is split in this way. The first is that it distributes the increase over more than 1 year, but avoids the need for the cumulatively higher rate increase required if we were to spread it over multiple years. And second, we are currently developing a novel benefit package that I am hopeful will be both attractive to policyholders and cost saving. I will talk about that more in a minute. The high-end value of that benefit package could be commensurate with the cost of the second-year rate increase of 25%. So if successful, the novel benefit package may be able to be offered in lieu of the second benefit increase, or at least offset it considerably. So those are the proposed rate increases, 52% starting next July and 25% starting in July of 2022. If approved, policyholders will be made aware of the need for these increases through multiple communication channels and at least 60 days before they receive the first one by way of a formal letter. The second request is for authority to offer the additional benefit designs that are laid out in the agenda item. These are designs not currently available to policyholders that we have identified as options that, together with other benefit designs authorized by the board in the past, could be used to create benefit packages that policyholders may take up in lieu of the premium increase, which would be implemented in July 2021. Today, we are asking for your authority to offer benefit designs that include, 1, a copay option of 10 to 20% that would create cost sharing based on which benefits are being paid. 2, an extension of the elimination period for both non-partnership and partnership policies. 3, reduced benefit periods by varying amounts for facility, comprehensive, and partnership policies, and a 3% compound inflation protection option for partnership policies. In addition, we are asking for the authority to develop and potentially adopt an enhanced partial benefit upon lapse provision that would be available to all policies that don't already contain the non-forfeiture optional benefit. As its name suggests, the partial benefit option would pay for limited long-term care services based largely on a policyholder's premium contributions over time should they stop paying their premiums as a result of the rate increase. It is not a cash buyout. The policyholder would only be eligible to receive benefits if they otherwise qualify to go on claim. We have not decided whether to implement this, but are seeking approval if we determine it is prudent. These new benefit design options, if authorized and if then implemented, would be used in conjunction with benefit designs currently available to create modified benefit packages for individual policyholders so they could ultimately realize a 0% rate increase for 2021. The new benefit designs would also be available to policyholders for partial mitigation of their rate increases once implemented. This means that the policyholder could choose a subset of these benefits that make the best sense for her or him. We do not anticipate using all of the benefit design modifications for each of our policyholders. Your authorization of these options gives us additional tools to address the needs of policyholders on a customized basis. I want to turn next to 2022. A few times I've discussed the challenges facing our long-term care program. I've also mentioned the emergence of novel long-term care insurance models that invest heavily in home retrofits, falls prevention, early and targeted in-home assistance, and other in-home supports with the goal of enabling policyholders to stay in their homes much longer and to delay costly institutional care for longer as well. As I've noted, this is what survey after survey tells us people want, and there is emerging evidence that these kinds of investments can significantly reduce costs. COVID has also brought to light the need for better ways of enabling seniors to age in place for longer. As the COVID death toll approaches 250,000 Americans, it's important to remember that about 25% of those individuals were infected in nursing homes. A year from now, at the November 2021 board meeting, our goal is to bring an optional plan design that incorporates state-of-the-art strategies for aging in place. If approved, we are confident that such an option can offer meaningful improvements in the lives of our policyholders and can more effectively manage costs over the long term. Care models designed to enable aging in place have typically received higher consumer satisfaction scores than conventional long-term care, but unfortunately, they are not widely available as offerings from commercial long-term care insurers. They exist, but they aren't yet to scale. Related models have been more widely employed in some of the state Medicaid, Medicare dual eligible demonstration projects authorized by Obamacare and in Medicaid managed care. So, in the coming weeks, we will be releasing a request for information about moving forward with a model that would be tailored specifically to CalPERS long-term care program beneficiaries, and after reviewing that information, we intend to move forward with a request for proposals. We will also continue with our ongoing consultation with national experts to help shape our new option. As I stated earlier, Our goal is to have such a model fully developed prior to the second premium increase that would be due July 2022, and that policyholders would choose who choose it could be able to offset most or all of the second rate increase. Before I conclude, I want to make a few additional comments. The first is that the volatility facing the long-term care market right now is very high. You are well aware of the challenges it has faced since its inception in the 1990s, but COVID adds an additional layer of unpredictability. Tragically, we know that COVID will change the mortality projections actuaries use to model future costs, but there is not a lot known about the long-term disabling effects on those who survive the disease. The institutions that house individuals who can no longer live in their own homes are also facing intense financial pressures, and many in the industry expect the type of consolidation that can decrease supply and increase costs. The regulatory environment surrounding nursing homes and assisted living is also likely to change as we learn more about what types of settings are safe in a pandemic and which ones are not. I raise these challenges because the premium increases we are proposing are our best estimates as to what is needed to stabilize the long-term care fund, but we cannot guarantee that premiums won't need to be raised again in the future. Similarly, we're hopeful that the proposed new benefit design that we will be pursuing in 2021 will give our policyholders a high-quality option that, over the long term, is better situated to stabilize their future cost exposure, but we cannot guarantee that such an option will eliminate the need for future rate increases entirely. Second, I want to again remind you and the public that the CalPERS Long-Term Care Fund is entirely distinct from its other funds. None of the actions you are considering today affect either the CalPERS Pension Fund or its health fund. The final thing I want to do is acknowledge again the difficult situation we now find ourselves in and the obvious hardship it creates for our policyholders. I can say with full confidence in our team and the exhaustive process we've undertaken over the last few months that if there were any other way of addressing the current shortfalls in the long-term care program, we would be pursuing them. Many of the challenges facing the CalPERS long-term care program are not unique to us. They are industry-wide. In fact, the majority of other long-term care programs are facing similar pressure to raise rates. The acute difficulty facing CalPERS's program is that it is a closed book of policies. By design and by statute, any shortfalls must be met either through improved investment returns, through modifications of the benefit, or through premiums. The asset allocation options the investment staff will be bringing to the board in February should significantly improve returns. And I'm hopeful that the benefit design changes I outlined above, as well as the one we will be developing in the coming year, represent meaningful alternatives for our policyholders. Of course, none of this means that the premium increases policyholders will be facing starting in July aren't a terrible burden. That concludes my remarks, and I'm happy to answer any questions.
Thank you, Mr. Moulds. I have Ms. Ortega.
Thank you, Don. Mr. Moulds, I have a question just to help me understand a little bit about the benefit design changes and how they relate to offsetting a premium increase. So I wasn't sure if I fully understood how you described each of the items would have sort of their own value towards how much it might buy down a potential member's increase. Is that right?
Yeah, let me try to add a little bit of detail, and it's perfectly reasonable for you to find them somewhat confusing. They are complicated. But essentially, the way it works is this. There are many different benefit designs within the CalPERS long-term care program. So over time, People have customized their benefits, and the benefits have evolved over the history of the program, which dates back to the 1990s. So the benefit design proposals that we're looking for approval for today essentially are added tools that will allow Long-Term Care Group, which is our third-party administrator, work with us to put together a customized policy for each individual member of the long-term care program that would bring their total cost down to zero. That's going to differ for different policyholders because the costs in their benefit design in their policies is going to differ from one to the other. So when they receive their letter 60 days in advance of the rate increase, they will have an option that is sort of tailored to them if they want to choose that option. They will also be told that they have the option of working with Long-Term Care Group to choose from the various options that we would be making available to buy it down in a more customized way. So if, for example, they decided that they didn't want co-pays but wanted a shorter duration or didn't want to give up their inflation protection, they would have the ability to do that. They would also have the ability to buy down their premium increase partially. So if they wanted to see a 25% rate increase, the folks at Long-Term Care Group could work with them to design a benefit option that would do essentially that.
So just one quick follow-up, if I may, Mr. Chair, is just, am I understanding correctly that an individual could potentially offset their increase for 2021 entirely by opting into some of these changes? Because I heard you say to zero, and that's what I want to understand.
That's correct. Yeah, by contract, we're required to provide a reduced value benefit design to every policyholder that would allow them to buy them down to zero. Those typically would result in other costs to members in the form of copays or extended termination periods, et cetera. But we are required to provide them with that option.
So let me ask this question, and not understanding what the requirements are under a program like this. What concerns me is the notion that an individual may opt into these benefit changes now in order to avoid cost increases in the short term. But when we think about the volatility issues and what the long-term risk is in the program, they may still be facing long-term premium increase. And what I'm wondering is if it wouldn't be better, although maybe not allowed, so you can tell me if that's the case, to have everybody facing some sort of increase in 2021, even if they opt into some of these changes that keep it from going as high as 50%. So I'm thinking, shouldn't we take action now to try to shore up the longer term risk? And if we instead give options to buy you down to zero, are we really doing enough to improve the plan long term?
So that's a great question. The challenge is that the contract binds us in two ways. The first is to provide, if the policyholder so chooses, the full benefits that they contracted with us to provide when they signed up for the plan. And the second is the option to take up these benefit increases or to buy down the policy to a 0% premium increase. So we cannot tell them that they should take a particular benefit reduction or similarly that they shouldn't. Does that make sense?
Yeah, so let me just confirm I'm understanding your response. There is no ability under the current contract to both pass on a premium increase based on the long-term cost of the program and offer the design changes. So again, what I'm getting at is like a floor of an increase that we know is going to be necessary over the long term, and not letting them just sort of avoid any impact in 2021.
That's correct. They need to be provided the option of fully buying down or buying down partially.
Okay, thank you.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. Yeah, on Ms. Ortega's question, I thought I was following, but I'm reminded that when we raised the rates to 85%, that was an overall increase for everybody. And after that rate increase, then the member had an option to select various copay options to bring down that 85% rate increase. So what I heard you respond to Ms. Ortega seemed like it's different. Clarify that for me.
Sure, I can try the rate increase. So the member will get a letter, as I understand it, and I was not there for the last rate increase, but the member would get a letter indicating the rate increases that they would be facing, and also informing them of their ability to buy them down. That they received that letter at least 60 days ahead of the rate increase, and at that time they would either they could either choose to buy it down entirely or partially, or to pay the rate increase. What I don't know for sure, and I can certainly get back to you on this, is the specific timing about when that buy down happens, whether it happens sometime between the letter and the rate increase, or after the person would be theoretically on the hook to pay the rate increase. I can answer that question for you offline, but in either event, the choices are essentially the same choices.
Okay, thank you. And so it's kind of a follow-up to that. Since this is a two-step phase process where we will be adopting the rate increases at the November meeting, what if those are not approved? Then would it change all these options that we're approving today?
So, this is the aging in place option that we'll be developing over the course of the next year. Is that the one you're referring to, Mr. Jones?
I'm looking at all of these options on the recommendation for today that we'll be voting on. But we're not voting today on the actual rate increase of 52% and 25% for year one and year two. Is that correct?
No, you will be voting on those today.
Okay, but it's not included in this item. I don't see it, rather. Maybe it's there. I just heard you comment. I just heard you make reference to it, but
I'm sorry. So we did not include the specific numbers in the agenda item because we were still working, as you heard in the investment committee yesterday. We have been working to try to finalize the recommended discount rate, and the specific premium increases are tied to the discount rate. So Scott Tarando yesterday translated the discount rate to the premiums, and those are the ones that we're bringing forward today seeking approval for.
Okay, yeah, because I think it's a little confusing to me then, because I was looking at the executive summary and it said that at the November 20th meeting, we will be adopting the rate increases. So whoever moved this need to include in their motion those rate increases that you referred to earlier. Is that correct?
That sounds like a good idea. Thank you.
Okay, thank you. And then the second part of my question is, at least a different part of the question is that, does this, do these proposed program changes reflect any input from the policyholders?
We have been, we have had some of these discussions at stakeholder meetings. We have not gone into a lot of detail about these options in particular. They are standard in the industry, and they're the ones that our actuaries have identified as being meaningfully valuable, meaning that they are the tools that they know they would be able to use to reduce premiums. The one thing that I want to reemphasize here is that we are asking for approval to include these potentially in the options that we use to buy down. So we do not anticipate using all of them for every policyholder. They are what I just described them as options, and policyholders would be able to choose among them.
Okay. Well, thank you, Mr. Knowles.
Thank you. Ms. Green-Ross.
Thank you very much. So I understand this is a necessary mitigation strategy that's very complicated. And I think the main concern the controller would have is we have 117,000 participants in this plan. I don't know what percentage would be right at the brink of needing long-term care or already in the middle of using long-term care. And so the concern, because this is a lot of moving pieces and very complicated, is the long-term care company contracted and doing the communications, or is our staff working with them? Because it seems to me like the communication is going to be so one-on-one with each individual, unless you can write a letter and explain when we get down to choices for each of the participants on, you can keep this benefit or you can keep that benefit and it's going to cost this much or that much. It seems like it's going to be very custom, designed. I don't know if all 117,000 are going to want an individual consult, but how will we be communicating this? Part one, and part two is, as part of that communication, how do we communicate with family members who, if the member's already getting long-term care and they need to apply and they're in the middle of using the long-term care program, and this transition is going on when you're using the care, how do you communicate to family members who may be caring for a parent and want to use the insurance to pay for that?
So a couple of things. First, in answer to your question about when our policyholders will be using long-term care, the height of the claims which means the payout will be in about 20 years. There are a lot of the policyholders, obviously, that will be going into claim sooner than that. On the question about communication, we would be using all of the avenues that you just described. So the PERS internal communication team, the website, our own staff, but also long-term care group. Our third-party administrator communicates as well, both through their call line and proactively. We have done this, unfortunately, before, raised rates significantly, and so we will be relying in part on past communication strategies, but we've started to look at them and improving them, and we're going to marshal all of those resources to over-communicate this to policyholders. Your point about caregivers is a very good one. I will talk with LongTerm Care Group and others that that are in this space about how we might effectively engage caregivers. My guess is that that can be challenging in some instances, but I know in other instances some policyholders have designated caregivers whose information Long-Term Care Group has, and I would need to walk through all of the HIPAA implications of those kinds of communications. But Long-Term Care Group is a third-party, is the largest third-party administrator in the country. They have lots of clients who have been going through similar challenges. They are versed in doing these rate increases, and I feel good about them as a partner in this.
I appreciate that. I know this is not going to be, none of this is easy. So thank you for that information.
Thank you. Mr. Rubalcaba.
Thank you, Mr. Chair. Don, I have a couple of questions on the customized plan and then a question on the process. It is a difficult situation. You stated yourself. So, but I still want some clarity on the on how the benefit options, benefit changes options are going to work. So, you mentioned that people will get individual letter. They can pick their customized alpha menu, for example. So, is the intent to give them, like, for example, say they pick a co-payment option of 20%, but you also give them the option of what 10% will look like. Will there be like a percentage increment in dollar amounts, or also like, for example, is there like a price list that says a co-pay option will mean plus, it will be a decrement of certain percent, or does it matter based on their demographic and age? And I mean, is it individual on that level, or is it like a price list, like the 180 day elimination period means so much?
Yeah, it would not be a price list. That amount of information can be difficult. What it would be is a customized, and when I say customized, I mean, they will typically take a group of like policies and say, okay, for these policies with this type of benefit design, these are the places where you can realize the most significant savings, and they would be offering two things to the policyholder. The first is just a pre-designed package to bring their premium increase down to zero, and the second is the option to contact Long-Term Care Group to work with them to design something that is more customized, and that's where the discussion would take place.
Thank you. And then the other question is more on the process. Once they make a selection, modifying their plan design, do they have the opportunity later on? I don't know. I know we don't have open enrollment periods, but do they have an opportunity later on to revert or make some other changes, either for more benefit flexibility in the premium, or perhaps because I had to use the word adverse selection, they realize that maybe 180-day elimination is not for them, and they can't wait that long. I mean, is there what's the long-term? I mean, I know it's kind of difficult just to figure out how to explain this now and decision, but what happens? Can we even think that far ahead?
Typically, there's some flexibilities, but they are limited. So, if you were to do a future buy down, for example, you could opt to go with different options, but you cannot necessarily repurchase insurance that you have given up in most cases.
Thank you for your explanations.
All right, thank you. So you know the request to speak. This is an action item. What's the pleasure of the committee?
Mr. Fechner?
Yes, sir.
I think Mr. Mo's presentation said it at the beginning. It's a difficult situation. Nobody wants to impose premium changes, but the situation is there's not enough investment coming in, and the mortality. I'll move the motion. I'll move the staff recommendation, Mr. Fechner.
Thank you, Mr. Rubalcaba. Is there a second? Mr. Miller? Mr. Miller, we're seconded, and I agree with you, Mr. Rubalcaba. There is no easy answer for this one. This is making the best of a bad situation, I think. I do have a couple of requests to speak from the public. Mr. Fox.
Can I interject at this point just to clarify that the motion is what Mr. Jones said should also be included, which is the specific recommended premium increases of 52% and 25% in the next 2 years.
That's correct. The 2-year phase-in of the premium, given the new discount, and also the menu of benefit changes, or potential benefit changes options, or option changes. Yes. I'll leave it at yes. Thank you.
Thank you, Mr. Jacobs.
Thank you. Mr. Fox.
Yes, Mr. Chair. The first speaker from CSR, Tim Behrens.
Thanks, Kelly, Rob, and committee. It's been a fascinating conversation. There don't seem to be any solutions. I understand why the rates have to go up. I just wonder whether or not there's something that we haven't thought of yet. I know other states provide in-home treatment to reduce the number of days people spend in nursing homes, which would be what long-term care provides. Maybe we should look down the road somehow of working together to produce some kind of a legislation that would reduce and enhance the quality of life for our senior citizens in California and keep them in their home and pay their family to give them those services and reduce the use of long-term care benefits. That's all I have to say. It's very discouraging. Thank you.
Thank you very much. Mr. Fox.
Yes, Mr. Chair. CSR, Larry Woodson.
Good afternoon, Larry Woodson, CSR. Thanks for the opportunity to comment. So I guess starting off, that one, I guess it goes without saying, because it has gone without saying, if CalPERS happens to lose the current class action lawsuit, it's back to the drawing board because it would face additional, probably significant increases. But I know you've got to deal with the matter at hand pending that. So it doesn't look like there's really any good option. I guess my only comment really is to kind of mirror Karen Green-Wass's comments about the communication strategy. After the stakeholders meeting, at the stakeholders meeting when this was covered, I expressed confusion about the rather bureaucratic, jargonish language in the options 1 through 6, and actually was provided a more layperson definition of some of these, and I think that needs to be part of the communication strategy if this is adopted and when it goes out to members, because the current language in this is, I mean, if it was confusing to me and probably some of the board members, the average subscriber is not going to get it. That's it. Thank you.
Thank you. Anyone else, Mr. Fox?
Yes, Mr. Chair, one last caller on 6D, JJ Jelenic.
Hi, JJ Jelenic, RPA, Director of Health Benefits. RPA is not taking a position on this agenda item. We did not have enough information to take an informed position. It's only today that we are getting the most basic information, such as the proposed rate increase. Even today, we lack details of the proposal and the financial implications of each. That is not enough time for a reasonable analysis. We do not know what information the board has had and chose to keep secret. It is, if like us, you are getting this information for the first time today, it is unlikely that it would be prudent to make a decision today. If you've been withholding information from constituents, that says something about your commitment to transparency. Many of these proposed changes make sense, or at least seem to, but maybe not. The only thing that is certain is that this situation is a mess. I wish you good luck and thank you.
Thank you. And Mr. Jelenic, your continued negative comments about what the board is hiding from the constituents is just getting old and tiring. We're not withholding information from the constituents, and we just want to leave it at that. So moving forward, I have Mr. Miller.
Yeah, thank you. I just had a couple quick comments. One, just again, thanks, Dr. Molds and the entire CalPERS team. This is another one of those, painful roads that we have to walk down, and there, unfortunately, we don't have a bunch of good options to choose from. They're all difficult and painful, but I think we do need to move forward with this, and this does at least provide some choices for our impacted policyholders, and it just, they're really avoiding the decision. Not going forward really just doesn't seem to be a good option for us, and I appreciate the hard work that went into all this. I also appreciated some of the comments about some of the lessons and some of the issues for the future, being forward thinking about the needs of for long-term care, assisted living, the challenges that institutions are finding in this, especially in this pandemic environment, and the real opportunities to kind of learn and partner with the industry, with the caregivers and the organizations that represent them throughout the country, and even the industries that are providing technological solutions and tools that may make helping to stay in home or even institutional care easier, whether that be telemedicine, whether that be biometrics and telemetry and those type of things. So I think it gives us a lot more to think about and potentially opportunities to, continue to cultivate those partnerships to make things better for our members and everyone in the future. Thanks.
Thank you. Ms. Brown.
Thank you, Mr. Chair. I just want to state that I'll be abstaining on this motion. I know too many people directly impacted by the last increase, and I don't know that they'll be able to stay in the program with this new increase. I'd just like to state that I hope that CalPERS has learned this very hard lesson, and that we don't jump into other product offerings or even investments we truly don't understand. Thank you.
Thank you. Seeing no other requests, a motion is before you. Ms. Hopper, please call the roll.
Margaret Brown,
Abstain.
Henry Jones,
Aye.
David Miller,
Aye.
Elena Ortega,
Aye.
Ramon Rubalcaba,
Aye.
Teresa Taylor,
Excused?
Shonda Wesley,
Aye.
Karen Green Ross for Betty Yee.
Aye.
Mr. Chair, I have 6 ayes, 1 abstention from Margaret Brown, with a motion being made by Ramon Rubalcaba and David Miller seconding it for agenda item 6D.
Thank you very much. Takes us to agenda item 7, information agenda item. 7A is summary of committee direction. Mr. Moulds.
Great. Thank you, Mr. Chair. I have 2. The first came from Ms. Brown, asking for specific numbers in each of the PPO plans, which we will make available to the board in very short order. And the second was a request for an answer to the question about the exact timeline of the benefit, the rate increase benefit mitigation options, and specifically whether they happen in advance of the proposed rate increase applying to particular members or at the same time. And we will make that information available as well.
Very good. Thank you. Seeing nothing else on that item. Item 7B is public comment. Mr. Fox, anybody from the public that wishes to make comment?
Yes, Mr. Chair. I believe we have Tim Behrens from California State Retirees.
Thanks, Kelly. I don't have any more comments today. Thank you.
Very good. Thank you. Anything else, Mr. Fox?
No, Mr. Chair, that concludes all public comment for this committee meeting.
Very good. So that brings us to the end of our agenda. I'm going to call to adjourn the meeting. Mr. Miller, do you think 1:30 for finance?
Yes, sir, Mr. Fechner, that will be perfect.
Okay. Well, thank you all for being here today. This meeting is adjourned. This is the last meeting of the PHBC for 2020. Hopefully 2021 will be better for all of us. So with that, on behalf of the committee, we wish you all a safe and sane holiday season, and we will be back with finance at 1:30. Thank you all for being here. This meeting is adjourned.